Hello, Partnering for Vaccine Equity Learning community members and others working to advance vaccine equity. I'm Bridget Courteau. I'm the Director of Group Learning for the learning community. And on behalf of our team at the Urban Institute and our partners at the CDC, thanks for being with us this afternoon. Though the Partnering for Vaccine Equity program is focused on COVID-19 and influenza vaccines specifically, we're aware that many of our learning community members are already working on reducing disparities related to other routine adult vaccines, or they're interested in expanding their scope to focus on adult vaccine access more broadly in the future. Today's session will provide you with a foundation for understanding recommended vaccines across the adult lifespan. We'll begin by looking at trends in vaccine uptake among adults over the past several years, and then we'll review the recommended vaccines themselves, brushing up on our knowledge of why they're important, when adults should receive them, and other key information that you can use when communicating about routine adult vaccination in your community. Before I hand things over to our speakers, I'm going to review a few key points about how this session will work. First, we offer live interpretation from English to Spanish during our events. If you would like to listen to the Spanish language channel, simply click on the globe icon in the Zoom taskbar at the bottom of your screen and switch over to Spanish. You've all been muted upon entry to this session. If you have a question for our speakers during the presentations, we ask that you use the Q&A tool that's also in the Zoom taskbar to submit it. The chat room feature is open today. We encourage you to use it to introduce yourself or comment on what you're hearing. However, try not to put your questions for the speakers in the chat because we might miss them there. Try to put those in the Q&A instead. If you have any technical difficulties at any point during the session, please send an email to our community manager's inbox. It's on the screen here. It's vaxequitylearning@urban.org so that we can assist you with troubleshooting and try to prevent that happening in the future. And finally, as with all of our learning community events, we post the slides and Spanish and English recordings for this session on our community website, and we circulate them through the weekly digests that go out through the CDC managed Adult Vax Program listserv, which all PAVE program members should be a part of. And now it's my pleasure to introduce you to today's speakers. Kathleen Holmes is a senior public health analyst in the Chief Medical Office in the Immunization Services Division at the Centers for Disease Control and Prevention. She coordinates Let's Rise, which we're going to hear about more today. It is the division's initiative to understand and address pandemic-related declines in routine vaccinations. Prior to joining the Immunization Services Division, Ms. Holmes spent a decade working in various global health positions at the CDC, including the Division of Global HIV/AIDS, the Center for Global Health, and Division of Parasitic Disease and Malaria. She also served on the COVID-19 response for 18 months, where she helped support COVID-19 vaccine rollout strategy and vaccine confidence and demand partnership work. Ms. Holmes was a Presidential Management Fellow from 2009 to 2011, and prior to her work at CDC, she served as a Rural Community Health Peace Corps volunteer in Benin. She has an MPH degree in Global Health from Emory University and a Bachelor of Science degree in International Political Economy and Biology from the University of Puget Sound. And we also have LCDR Neil Murthy here with us today. Neil is a medical officer with the United States Public Health Service and works in the Immunization Services Division at the Centers for Disease Control and Prevention. He co-leads the Advisory Committee on Immunization Practices, and specifically their Combined Immunization Schedules Work Group, and he leads the development of the annual adult immunization schedule for routinely recommended vaccines. He served on various roles on the CDC's COVID-19 response, including analyzing vaccination uptake and coverage, educating healthcare providers about COVID-19 vaccines, and building the informatics infrastructure to help capture COVID-19 vaccinations. And more recently, he served on CDC's Mpox response, where he helped develop interim clinical considerations for vaccine use as part of the 2022 Mpox outbreak. He was an epidemic intelligence officer from 2016 to 2018, and he completed his preventive medicine residency at CDC in 2020 and is board certified in preventive medicine. He's a graduate of the University of Texas Southwestern Medical School, the Harvard School of Public Health, and Northwestern University Medill School of Journalism. He's deeply passionate about combining his interest in medicine, public health, and communications. So as you can see, we have a superstar set of speakers today with a lot of experience. I'm so pleased that you could both join us today. Thank you for being here and for sharing with us. And now we can get started. I'm going to hand things over to Kathleen first. So welcome, Kathleen, and just let us know when you're ready to switch slides.
Great, thanks, Bridget, and good afternoon, everyone. I'm excited to be here with you today. As Bridget mentioned, I will be providing a brief look at trends in adult vaccination coverage this afternoon with a specific eye to understanding the impact that the COVID-19 pandemic had on adult routine vaccination coverage, as well as CDC's thinking around how to address pandemic-related declines in routine immunizations. Then I'll hand it over to my colleague, Neil, to provide a more detailed overview of adult routine vaccines and what you need to know. Next slide. So as background, and as many of you are likely aware, routine immunization orders and administration declined in the United States in the wake of the COVID-19 pandemic. Soon after the national emergency was declared, vaccine for children vaccine orders decreased significantly. As you can see from the graph on the right, by mid-April 2020, orders for non-flu vaccines had decreased by 3 million doses, shown in the solid blue line. Routine vaccine orders and administration have subsequently rebounded since this time, but unevenly. Next slide. So to better understand the impact of the pandemic in the current state of routine immunizations for both children and adults, CDC stood up a data work group in August composed of staff from across the agency. On this slide, you'll see the variety of data sources that the work group is examining, including vaccine ordering data, survey data, immunization records, and claims data to better understand what the impact of the pandemic was on routine vaccination coverage. Next slide. So today I'll be focusing my presentation on the impacts of the pandemic on adult routine vaccination coverage. Next slide. So while adult vaccination coverage has slowly improved over the past decade, as you can see in the table on the right, vaccination coverage fell substantially short of the Healthy People 2020 targets, with the exception of the herpes zoster vaccine prior to the pandemic. Thus, for adults, the goal is not only to catch up adults that delayed vaccination during the pandemic, but to continue to increase uptake above pre-pandemic levels going forward. In regards to the pandemic's impact on adult vaccination coverage, thus far, we found it hard to assess, in part because there were a number of changes in ACIP recommendations during the same time period, which may have changed adult and providers' vaccination behavior. So it's hard to attribute changes directly to the pandemic. Next slide. With that said, I'll present claims data that show what some of the impacts of the pandemic might have been. Here we can see a large initial drop-off in claims among Medicare FFS beneficiaries 65 years and older for pneumonia, Tdap, and shingles vaccines. You can see the light blue bars for the period of time from March to July 2020 are significantly shorter than the dark blue bars for the same period in 2019 across all 4 vaccines. Declines were similar across all racial and ethnic groups. Since this time, preliminary analysis indicates that Medicare claims rates have partially recovered, which you can see for the PPS V23 vaccine, which is the vaccine for pneumonia, starting to go up by June of 2020. However, more detailed analyses of Medicare claims data through the first part of 2022 along with additional birth cohort analyses of the 2021 NHIS and BRFSS surveys are still ongoing. Next slide. So the drug manufacturer GSK and the health information technology company IQVIA also analyzed adult vaccination claims data, which they published online. They found that national vaccination claims across all markets declined in spring of 2020 and remained below pre-pandemic levels throughout 2020 and 2021, except for a brief period in the fall of 2020. They found that the declines in claims were widespread across all vaccines, all race and ethnicities, payment types, with some variability by location. And GSK estimates claims dropped by a combined 18% in 2020 and 2021 as compared to pre-pandemic claims levels, which is equivalent to an estimated 12 million adult non-flu vaccine doses missed over the past 2 years. Next slide. So moving to influenza coverage. Next slide. Unlike other adult routine immunizations, adult flu vaccination coverage actually increased overall during the 2 flu seasons that followed the onset of the COVID-19 pandemic. Flu coverage increased on average by 4 to 6 percentage points among adults 50 years and older, which are marked by the red and the orange lines on this graph. After the pandemic began, with the greatest increase among adults 65 years and older. By contrast, if you look at the purple line on the bottom, you'll see that among younger adults aged 18 to 49, that influenza coverage remains stable and low, with only 1/3 of younger adults vaccinated for flu prior to and during the pandemic. Next slide. So when taking a closer look at flu coverage by sociodemographic characteristics, such as race and ethnicity and urbanicity, we found that flu vaccination coverage increased by approximately 4% among white adults and adults that identify as other races, and remained stable among Black and Hispanic adults during the COVID-19 pandemic. Decades-long disparities in flu vaccination coverage by race and ethnicity persisted, but did not worsen during the pandemic, with flu coverage remaining more than 10% lower among Hispanic, Black, and other multiple race adults compared to white and Asian adults. While flu coverage increased among adults in all urbanicities during the 2020 to 2021 flu season, coverage began to decline among rural adults during the last flu season from 2021 to 2022, while it continued to increase among adults in non-rural areas, thereby widening disparities in coverage between urban and rural adults by an additional 2 percentage points. Next slide. Maternal influenza vaccination coverage, unlike the general adult population, significantly decreased by 8 percentage points over the course of the pandemic, steadily declining from 57.5% during the 2019 to 2020 flu season to 49.6% during the 2021 to 22 flu season. Influenza coverage decreased most among white pregnant women, and this is the first time coverage has declined among this group. Next slide. So in response to initial declines in routine vaccination Medicare claims, the National Adult and Influenza Immunization Summit members put out a call to action to improve routine vaccination coverage for adults during the pandemic. CDC posted this call to action on our adult immunization landing page, along with links to additional adult immunization resources, toolkits, and strategies. Next slide. In our response to pandemic-related declines in routine immunizations, CDC launched a new initiative, Let's Rise, in January, which stands for Routine Immunizations on Schedule for Everyone. Through Let's Rise, we are focused on collaborating with healthcare providers, health departments, public health and community partners, schools, and daycare centers to address pandemic-related declines. Efforts bring together and make readily available relevant data, actionable strategies, and evidence-based resources that can be leveraged by partners to get Americans caught up with their routine immunizations. We have not received any additional funding for this effort, so it's really about prioritizing and targeting existing resources and activities to communities that have fallen behind on their vaccinations, and in some cases, when existing efforts are not sufficient, better understand what is needed to strengthen routine immunization. Next slide. So here you can see a summary of the evidence-based strategies that we know work well to increase vaccination coverage. For this group, I'd like to hone in specifically on what we believe public health partners can do to get routine immunization back on track. I don't think as you look at this list, anything is new here. For adult immunizations, vaccination coverage is low in general. So beyond a focus on addressing drops in pregnant women, we also need to focus on strengthening adult routine immunizations in general. The message is not so much the importance of catch-up in this group as it is the importance of adults staying up to date on their vaccinations. Next slide. You can find out more information about Let's Rise on our webpage, along with relevant data, actionable strategies, evidence-based resources, and communication assets that can be leveraged by partners for this work. The URL to this webpage is on the bottom of the slide. And this webpage is really meant to be a centralized information hub for routine vaccination catch-up, a one-stop shop that you don't have to search for data and resources across CDC's multiple web pages. Next slide. So thank you again for the opportunity to be with you here today, and I'll be happy to take any questions at the end of our presentations. So now I'd like to hand over the virtual mic to Neil for his presentation.
Thank you so much, Kathleen, and give me a minute as I try to share my screen here. Okay. All right, can everyone see my screen?
We can see it.
Perfect. All right. Well, good afternoon, everyone. And thank you so much, Kathleen. My name is Neil Murthy. I'm a medical officer here at the Immunization Services Division at CDC. And, Kathleen did a fantastic job highlighting, the impact that the pandemic had on vaccine uptake of all the routinely recommended vaccines across the adult lifespan. And what I want to do here is I want to shift gears a little bit and just kind of talk about what are those routinely recommended adult vaccines, and when are they administered? Like, kind of think about what target populations you should be thinking about. Which vaccines for which target population. So with that, let's get started. There are many diseases out there that impact adult populations, and we have for which we have routinely recommended vaccines. And during this presentation, I'll touch on the vaccine recommendations for many of these diseases. But what I'd like to bring your attention to is the newest member of this group, and that is COVID-19. For the past, 2.5 years or so, we've been treating COVID-19 as a special category with special recommendations. But for the first time in the 2023 adult immunization schedule, COVID-19 is now going to be included as any other routinely recommended vaccine. And that's a big shift in mentality, to think that we're normalizing COVID-19 vaccine recommendations just as we would for any other vaccine recommendations that we have on the schedule. And another shift in mentality that I want you all to think about here is we often think of routine vaccinations as being a childhood thing. You see babies going to their pediatrician offices for their well child checks to get vaccines. But what I really want you all to think about when we talk about routine vaccines is we need to shift that conversation and our mindset to thinking about the importance of vaccination across the whole lifespan. And this really is the best first line preventive measure that we have here in public health practice. So over the course of this presentation, what I hope to accomplish is that you'll learn some basic facts about many of the vaccine preventable diseases out there. And it's also important to recognize key target populations who may need certain vaccines. You know, a 20-year-old might need a different set of vaccines than a 60-year-old, and we'll talk a little bit more about that in this presentation. And my ultimate goal here is for you to understand, to truly understand and appreciate the importance of adult vaccinations and how vaccines play such an important role in preventive care throughout a person's life. What I will not cover is stuff that's really kind of in the weeds for healthcare providers. So like dosing schedules or regimens, that's really more for a healthcare provider audience. We won't really talk much about trade names of all the different vaccine products or vaccines that are recommended for travel purposes. You know, we also won't go into all the nuances of certain medical conditions that may warrant certain vaccines. Again, really that conversation's for healthcare providers. And I won't also talk about, you know, vaccinate with confidence initiatives or things of that nature where, you know, it encourages folks, best practices to encourage folks to get vaccinated. That kind of stuff is a little bit outside the scope of this presentation. And you know, all the nitty-gritty details of the 2023 adult immunization schedule, I won't cover all of that. I don't have time for that. But what I would recommend is that if you are curious to know about all the details about the 2023 adult immunization schedule, you may access it at this web URL link presented here. So with that, let's get started. We'll first talk about the vaccines that are recommended for everyone based on age. And for the purposes of this talk, we're going to break up the adult lifespan into 4 distinct categories. We have the young adults, the 19 to 26-year-olds, the 27 to 49-year-olds, the 50 to 64-year-olds, and those who are 65 plus. So we'll begin with this youngest age group. And here are the vaccines that are recommended for all adults in this age category. And, you know, we heard a little bit about influenza already. Every adult, regardless of age, needs a flu shot every year. And, you know, we all know that influenza is a highly contagious respiratory illness that's spread by sneezing or coughing. And each year it takes a serious toll on our population. Here's a pyramid that just shows the burden that this disease has, you know, with each flu season each year. And as you can see by this map of the United States, there's like by the purples and reds on this map, we've had a lot of influenza activity across the United States this past influenza season. So it's just so important that everyone who's eligible to get vaccinated every year gets vaccinated with influenza. And there are multiple flu vaccines of which I've listed here on this slide as well. So we'll move on to Tdap. This is a combination vaccine that consists of tetanus, diphtheria, and pertussis. And these are all really terrible diseases. Tetanus is also commonly known as lockjaw. It's characterized by this fever and muscle spasms and stiffness all throughout your body. And here you can see this child, you know, with these tight muscle spasms. And you know, often it's caused by these spores that enter your body through a dirty or contaminated wound. And then once inside your body, these spores germinate and produce this potent toxin that causes these terrible muscle spasms. Diphtheria is a bacterial disease, also caused by a toxin. It primarily impacts the respiratory system and produces this thick gray coat in the throat or nose that makes it very hard to breathe or swallow. You can see that in you know, that thick gray coat at the back of this child's throat here. And then pertussis is also known as whooping cough, and it's this, you know, this bacterial disease where they have this uncontrollable, violent cough, where they just cough, you know, so hard, and then take a deep breath to inhale, and it's that inhalation that causes that whoop sound for pertussis, hence the term whooping cough. And pertussis is particularly deadly for babies less than a year of age. So the recommendation for Tdap is that everybody should be vaccinated with TD, which is without the pertussis component, or Tdap, at least once every 10 years to combat waning immunity. And, you know, you may need an extra dose of TD or Tdap if you have a dirty wound, especially if your last tetanus toxoid containing vaccine was more than 5 years ago. And another key thing that I would like for everyone to remember is that every pregnant woman needs 1 dose of Tdap during the 3rd trimester of every pregnancy. And this is really to protect the newborn against pertussis, because the mother can pass on her maternal antibodies to the infant and protect the infant during that critical 1st year of life. So we'll move now to HPV. HPV stands for human papillomavirus, very common sexually transmitted disease. What's concerning about this is that it can cause multiple different types of cancers, cervical, penile, anal, vulvar, vaginal, throat cancer. The key thing to remember here is that everyone up through age 26 years needs to be vaccinated, because HPV vaccines can prevent over 90% of these cancers. And ideally, you should start this vaccination process early, like, as early as the age of 9, because, as a rule of thumb, the number of doses that you get depends on how early you start the series. It's a 2-dose series if you start the first dose between 9 through 14 years of age, or it becomes a 3-dose series for those who start at 15 years of age or older. And since many of these adults, these young adults, 19 to 26 years of age, may not have finished the recommended series in that late adolescence, it's always a good idea to check to make sure that these young adults are up to date on HPV vaccine recommendations. So next we'll talk about hepatitis B, and this is a viral infection that's spread through blood, semen, other bodily fluids, infected, with Hep B virus. And so what happens is that it causes this chronic, lifelong liver infection, liver failure, and liver cancer. In fact, hepatitis B can cause up to 80% of liver cancers. And the key thing to remember about Hep B vaccine is that it's recommended for all adults up through 59 years of age. So definitely within this age group of 19 to 26, but it's all adults up through 59 years of age. There are multiple types and dosing regimens of Hep B vaccines, which I won't go into, but it's there in the schedule. So you're welcome to look at the adult immunization schedule to learn about the types and dosing regimens of Hep B vaccines. And finally, of course, the COVID-19 vaccines. We've talked about this for years now at this point, but here is everybody 6 months of age and older are recommended for COVID-19 vaccination. Here's the primary series for the general population for Moderna, Novavax, and Pfizer BioNTech. And the key thing to remember about this is to stay up to date on all recommended COVID-19 vaccines, including any recommended updated bivalent boosters. So whenever you assess your patient populations, make sure that they're up to date on COVID-19 as well. So we'll move on to the next age category, adults who are 27 through 49 years of age. And essentially all the vaccines that I spoke about earlier pretty much stay the same, with the exception of HPV. HPV is recommended universally for all adults up through 26 years of age. So it's not recommended really for this population unless there's certain conditions or risk factors that then you may consider HPV vaccination, but it's not universally recommended for everybody in this population. So all adults in this age category should receive influenza, Tdap, Hep B, COVID-19, just as how we discussed earlier. The next age category is adults who are 50 through 64 years of age. And again, we see many of the same vaccines that were recommended in the younger age groups. The difference that I alluded to earlier, is that Hep B vaccines are universally recommended for all adults up through 59 years of age. So at age 60 years and older, there are risk-based recommendations for adults. We can, time permitting, we can talk a little bit more about that a little later in this presentation, but it's universal. Hep B is universal up through 59 years of age, and then there are risk-based recommendations for Hep B vaccinations for those 60 years of age and older. And the vaccine that is new for this age group, those 50 years plus, is zoster vaccination. And it's recommended for all adults 50 years of age and older. Zoster is essentially a reactivation of the virus that causes chickenpox, and it presents as a very painful skin rash. Many of us have had chickenpox when we were kids, and when we recover from chickenpox, essentially the virus stays dormant in your spinal cord. And as you age and your immune system starts to wane, the virus can get reactivated and then reemerge as a very painful rash on one side of your body. And here's some pictures of how that rash looks like. And one of the most painful and worst complications of herpes, zoster, is that it can cause this pain that lasts for years called postherpetic neuralgia. And one out of 3 people in the United States will develop shingles. So it is a common, it's very common, and that kind of emphasizes the need for vaccination against this terrible, terrible condition. We'll move on now to the oldest age category, adults who are 65 years of age and older. Again, like I mentioned earlier, Hep B is only recommended up through 59 years of age. So it's not in this list for this age category. But what's new for this age category is pneumococcal vaccine. And pneumococcal vaccine, all adults 65 years of age and older should receive pneumococcal vaccination. Pneumococcal infections are characterized by a whole bunch of diseases caused by a bacteria called Streptococcus pneumoniae. And it can infect multiple areas of your body. You can get, a pneumonia in your lungs, a bacteremia, a blood infection, sinusitis, sinus infection, meningitis, an infection of the lining of your brain and spinal cord, ear infections, otitis media. And it spreads mainly through, respiratory secretions, saliva, mucus, and whatnot. Pneumococcal pneumonia causes 150,000 hospitalizations, and meningitis and bacteremia from pneumococcal, this particular pathogen kills more than 3,000 people each year. So adults in this oldest age group are particularly at risk for this. So that is why it is universally recommended for all adults 65 years of age and older. And last but not least, I want to mention briefly here that in 2023, a new recommendation for adults 65 years of age and older is that the high dose or adjuvanted influenza vaccine should be used in this older age group, just so that to elicit a robust immune response in this oldest population. If the high dose influenza vaccine or adjuvanted influenza vaccines are not available, then any other age appropriate influenza vaccine should be used, because don't miss an opportunity to vaccinate just because you don't have the high dose influenza vaccine readily at hand. So we've covered the entire lifespan and talked about the vaccines that are routinely recommended. I want to now just shift gears a little bit and now talk about the vaccines that may be recommended based on certain medical conditions for just some adults at different stages of the lifespan. So, we talked about vaccines that are universally recommended based on age categories, on those 4 age categories, but now we'll talk about vaccines that are recommended based on certain medical conditions. So here's a list of all the vaccines that are recommended only just for some adults. And just to orient you for the next couple of slides, I'll walk through each of these vaccines one by one. And in the upper right-hand corner, I'll show the age range for which each vaccine would be recommended among some adult populations. So we'll start off with MMR, which stands for measles, mumps, and rubella. It is a live attenuated vaccine, meaning that the microbes in the vaccine are live, but have been weakened in order to produce an immune response without causing the severe effects of the disease. It's a combination vaccine, like I mentioned, and these are all highly infectious viral respiratory diseases. Measles is particularly dangerous for babies and young children. It's characterized by a rash, high fever, cough, runny nose, red watery eyes. It can lead to severe pneumonia, brain inflammation, and death. Mumps involves pain and swelling and tenderness of the salivary glands around the cheek and jaw area, which you can see here, the swollen cheeks in this child. Severe complications include meningitis, inflammation of the pancreas, brain, testicles, and ovaries. And rubella is characterized by a rash that starts on the face and spreads to the rest of the body, along with low-grade fever, headache, a cough, and runny nose. And the most dangerous and serious complication of rubella is that if an unvaccinated pregnant woman gets infected with rubella, she can have a miscarriage or her baby can die after birth. So rubella causes severe birth defects in a developing baby. So that's kind of the biggest concern with rubella. So as I mentioned, as you can see in the top right-hand corner, MMR is recommended for the first 3 age categories. So those 19 all the way through 64 years of age, and it's not recommended for the oldest age group. But the key thing to remember here is that because this is a live vaccine, you cannot give it to folks who have a weakened immune system or to pregnant women. So only a subset of adults can receive this vaccine. Folks who have no evidence of immunity to measles, mumps, or rubella should receive 1 dose. And what counts as evidence of immunity? In general, if you're born before 1957, you're presumed to be immune due to natural infections, since these diseases were just so common back then. And if you have received MMR doses in the past and it's documented in your medical record, then you are considered, or if you have laboratory evidence of immunity, then you are considered immune. We'll move on to varicella, which is the vaccine that causes chickenpox. Chickenpox is this characterized by this fever and causes a diffuse, itchy, blister-like rash all over your body. Like the MMR vaccine, varicella vaccine is a live vaccine, so it should not be given to folks who have a weakened immune system or to pregnant women. So again, only a subset of adults can receive this vaccine. Evidence of immunity includes birth in the United States before 1980, documented receipt of having varicella vaccine with 2 doses, documentation of having a history of chickenpox, and if you have any laboratory evidence of immunity or disease. We talked about zoster vaccines earlier, where it was recommended to everyone 50 years of age and older. But for folks who are less than 50 years of age, only those who have a weakened immune system, only those who are immunocompromised should get zoster vaccination. And I briefly alluded to this earlier as well. We discussed about HPV vaccine for young adults up through 26 years of age, but for adults 27 through 45 years of age, only some adults in this age group may need an HPV vaccine depending on certain risk factors. So if you're between 27 and 45 years of age, just talk to your healthcare provider to see if you need an HPV vaccine depending on your lifestyle. And we've talked about pneumococcal vaccination that's universally recommended for all adults 65 years of age and older. But for those who are younger than 65 years of age, only some adults would need pneumococcal vaccination if they have any of the risk factors that are presented on this slide here. And similarly for hepatitis A vaccination, it's only recommended for some adults who may be at risk for severe disease from hepatitis A. And those risk factors are listed here on the slide. Anyone who is not at risk but still wants protection from hepatitis A can still be vaccinated. And essentially, hepatitis A, the symptoms of Hep A infection include fatigue, nausea, stomach pain, jaundice. But unlike hepatitis B, most people with hepatitis A do not have any long-lasting illness. And we've already discussed, Hep B vaccination earlier. It's routinely recommended for all adults up through 59 years of age. But for those who are 60 years of age and older for hepatitis B, only those with certain risk factors are recommended for vaccination. And those risk factors are listed here. It's important to keep in mind that anyone aged 60 years of age or older that without any known risk factors may still receive hepatitis B vaccine if they wish to do so. So just because, if you have somebody who's older than 60 years of age who does not have any of these risk factors and they still want to be vaccinated, go ahead and just give them the vaccine. Meningococcal vaccination is also recommended for only a subset of adult populations, and the risk factors are listed here. Meningococcal disease can cause severe and sometimes deadly infections of the lining of the brain and spinal cord and can lead to bloodstream infections. And it's, again, also primarily spread by respiratory means. And last but certainly not least is Haemophilus influenza type B, or HIB. Only folks who do not have a spleen or who had a stem cell transplant should be vaccinated for HIB. HIB can lead to pneumonia, bacteremia, meningitis, and it's also spread by respiratory droplets. So that was a lot of information that in the preceding slides that I threw at you. We talked about vaccines that are recommended across the adult lifespan based on age. We also talked about vaccines that are recommended based on certain medical conditions or only recommended for only some subsets of the population within each age group. So, I would like to just take a moment here and share with you all a very handy resource called the Adult vaccine assessment tool. And this is a questionnaire that's essentially geared for the lay public to figure out which vaccines that they might need. And all what you have to do as a patient is you just have to complete this questionnaire by answering a few basic demographic questions. And based on your responses, you will receive a list of vaccines that you might need. And what you can do as a patient is you can just print out this list of vaccines and take it to your doctor at your next doctor's appointment and start that conversation as well, about what vaccines that you might need. So this is a really good resource that we have for patient populations as well. And it is also available in Spanish too. So that's a good thing to remember. So I want to end with a few general thoughts on vaccine administration. Some big general rules of thumb. I can't stress this enough, but don't ever miss an opportunity to vaccinate. Whenever you meet someone of any age, just think about, what vaccines might this person need based on their age group. Or, if you think about certain individuals with certain medical conditions, just think about what vaccines they might need based on those medical conditions, and start that conversation. Remember, recommending someone to get a vaccine is such a powerful motivator and you can literally push the needle forward, no pun intended, in getting that person vaccinated just by having that conversation from a trusted source. Another thing that I want to mention real quick is that most non-live vaccines can be administered at any time before or after a different non-live vaccine. So, if somebody said, well, I just got my flu shot yesterday, can I get, this other vaccine? Or if it's a non-live vaccine, then the answer is yes. They can be administered at any time before or after another different non-live or live vaccine. Live vaccines, on the other hand, must be administered either at the same visit or be separated by 28 days. So you do need to wait in order to to help the immune system mount an effective response. They should be either administered on the same visit or separated by 28 days. So just always remind everyone to talk to their healthcare providers for vaccine recommendations based on their individual situations. That conversation can go a long way in getting folks vaccinated. So with that, I'd like to thank my team for their help with this presentation, and thank you for your attention, and I'm happy to take questions as well.
Thank you so much, Neil and Kathleen, of course. So we do have time for some Q&A. We do have a couple more slides we're going to share at the end to tell you about some upcoming learning events. And if you all have joined us before, we typically do a satisfaction poll right before we close, but we definitely have some time for Q&A first. So take a minute, digest if you need to, type any questions in. Neil, I saw actually both of you there was more of a kind of a comment about vaccine misinformation that maybe both of you might want to consider that came through the Q&A, and any thoughts you have, any observations that you all maybe have made about as part of the CDC team kind of doing this work and communicating about vaccines, about this newer era of vaccine misinformation, and how, if at all, it's kind of changed your approach, or how the folks working on the ground might consider that when they're crafting messages. Because I think the comment came from the place of, people on the line here might be using slides like these, we share our slides afterwards, to kind of create some messages about vaccines. And so if there are tips like, do this, word it like this, phrase it like this, that could be helpful. So you can answer that now or think about it. I have one other question too, while we're waiting for others to come in. But do either of you have thoughts on kind of this idea of phrasing and how critical it is to think hard about what you say or what you put into a message, because so many things can get taken out of context?
Yeah, maybe I'll jump in, and then Neil, if you want to add on. One thing that I can say is anecdotally, at least in the pediatrician space, we are hearing that as a result of the COVID pandemic, that a lot more parents, and this may be, I'm not sure how much this extends to the adult vaccination space as well, but are asking a lot more questions about vaccines. And so I think that this is a really important point that it's really important to be able to address misinformation. And I know that there were a lot of great resources that were developed during the COVID-19 pandemic. There's a website, I can find a link to it and put it in the chat, but really emphasizing a good strategy for addressing misinformation is to make sure that you start with correct information, you address the misinformation in the middle, it's kind of like a sandwich, and then you end with the correct information to avoid continuing to propagate any misinformation. So maybe that's what I would say. I think that this is going to be really important going forward, not only in the COVID space, but also for routine immunizations. And I think, you're really valuable, trusted messengers in this space to help get out the right information to help people make the choice that's right for them.
Thanks, Kathleen. Anything to add, Neil, or do you think that covered it?
I think that covered everything.
Okay. So I did see one question about the slides and I answered, we will be making the slides available after the session. Another Q&A came in. And this is more, I'm not sure that anybody on the line can really answer this, but there's a question about whether there's discussion of a program like PAVE for other recommended adult vaccines. And so that would be a level of reading the tea leaves I'm not sure any of us on the line could answer. But I think we also have been thinking along those lines as kind of the future of this program, which has been so COVID and influenza focused. And now, there's this network of organizations that have been working on vaccine confidence and access. And so I think it would make sense, but certainly there's no, I don't think any of us have that information. But we are hopeful that some of the information, if and when PAVE does come to a close, that a lot of this learning can be extended to other public health work, other things that you're doing in your communities, even if the PAVE program no longer exists. Let's see, so thank you, Kathleen. I see that you've chatted a link. One thing that I wanted to encourage as we're kind of wrapping up is that some PAVE funded organizations do have supplemental funding, kind of time limited to work on other routine adult immunizations beyond COVID and flu. And so I'm sure there are some in this audience who are part of organizations that do have that funding and could be creating resources for your communities that have gone beyond COVID and flu and are very focused on some of these other vaccines that we've heard about today. And so I wanted to encourage you, if you are one of those organizations and you have created fact sheets, social media messaging, things that are shareable with the community, think about posting them on our community library and the website. Think about sharing them with a vaccine resource hub where there's lots of great tools and resources compiled. And we know people are going on there and downloading and looking for things every single day, every single hour. So really consider sharing what you might be creating. I know at the Urban Institute, we support community-based organizations doing the PAVE work, as well as our role as group learning manager. And some folks, some of my teammates have created a fact sheet that I think Leandra is going to be chatting out, or we can share in the materials, a quick one-pager that just kind of covers some basics on the on other routine adult immunizations. So just to plug, encourage you to share what you're creating. I think there's interest great interest in this in the learning community and getting hands on some of those resources.
Bridget,
Kathleen, go right ahead.
Yeah, if I can just jump in and say, as a part of the Let's Rise initiative, a lot of what we're doing, because there are so many resources that have been developed, we don't want to reinvent any wheels. So we are also working on putting a toolkit together of existing partner resources that could be utilized for catch-up work. And so if you're also able, I can share my email address. We have access to the learning community and are looking there. But if there are any particular resources that are kind of drop and play, letter templates, things that can be adapted and used by others, we'd be really interested in highlighting that in our toolkit as well.
Great, thank you. And we will share anything that we see that we aren't sure if you've seen with you as well. Okay, we have maybe time for one or two more questions, so send them in now. And I had a question, Kathleen. I know you had you showed a screen about with some flu data and mentioned that that there was that sort of the trends went in the other direction compared to some of the other vaccines that you were looking at, and more people were getting the vaccine during the flu seasons. And of course, I think I have an idea of why, but you know, what does that say about kind of the success of the co-promotion of those two vaccines? Was that just fear, people understanding that they didn't want to get both COVID and flu, or what are your thoughts on why the different direction for that particular vaccine?
Yeah, I think you're exactly right. I think just increased awareness of the importance of vaccination against respiratory diseases was brought to light during the COVID-19 pandemic, and also wanting to prevent, co-infection of that. But I think it was just people were, particularly seniors who were at higher risk for severe outcomes of COVID, were going to the doctor's offices to get, COVID vaccination. And so I think vaccination in general is just top of mind.
Mm-hmm.
I
And
don't know,
many
Neil,
of, oh yeah, go ahead.
Neil, if you have anything else that you want to add, but that's my understanding.
Yeah, I mean, it makes sense that I don't know. I'm just thinking like how probably that organically that conversation came up, when a senior citizen went to their healthcare provider to get vaccinated against COVID. Probably that's when it would be a natural like segue into flu, so that I could see that happen.
Mm-hmm.
And my goal and my wish is like segue into pneumococcal while you're at it, segue into RSV.
To jump over,
yeah, RSV rather, yeah, exactly, to shingles. So it's like there's so many different ways we can do to help promote a vaccine uptake across all the routinely recommended vaccines.
And many of our learning community members were over the last two flu seasons really working on sort of the co-promotion. So I think, some of that could be reflected in this data, that messaging about the COVID vaccine was closely tied to messaging about the flu vaccine. And the data is showing that kind of messaging, may have been working. So all right, I see we have about a few minutes left, so I want to make sure that we have some time, and you all can still chat questions if you have them while I'm plugging some of our upcoming events. Anything we don't get to answer here, we can try to get in touch with you and answer over email. But I did want to share some things with you while we launch our satisfaction poll. So so take a second to do that if you don't mind. We really appreciate you participating in that poll. And we also have several, it's a very busy month for us, and next month is also going to be very busy. And we have several things to tell you about that are coming up in the next couple of weeks. So next week we will have, as part of our every third Wednesday social determinants of health learning session series. We have a session next Wednesday at 12 p.m. Focused on changes to Medicaid enrollment policies, and specifically what some call the unwinding of Medicaid, or the restart of redeterminations, end of continuous enrollment in Medicaid for many populations. So you may have heard about it in a lot of different terms, but those changes are what is going to be the focus of next Wednesday's event. All of these have open registration, and Leandra's going to be chatting them while I bring them up. And then April 24th, which is a Monday, we will be introducing the CDC's Vaccine Activity Planner. This is a new tool that some of our colleagues on the PAVE program team are very excited to tell you all about. On the 27th, we are hosting a limited capacity qualitative data collection training. That session is full, but I wanted to mention it here, not to frustrate you, but because I encourage you to get on the wait list if you're interested in that. We typically do take folks off the wait list. We have cancellations or no shows. So if you're interested, or if we see a lot of waitlist interest, we might offer it again. So if you're interested, please consider sending an email to vaxequitylearning@urban.org. It could be short. Just tell us, I'm interested in the April 27th session, and we'll add you. And then soon on May 2nd, tentatively at 1 p.m., but we are firming up the time. We are scheduled to have a webinar on the end of the public health emergency, or the PHE, as it's known in short, and what that means for vaccine access. And we have more coming in May that we couldn't even fit here on the screen. So those are the most, those are the things that are coming up in the very near future. And we hope you join us for all or some of them, or catch them on demand after the fact. Right. Well, with that, I just want to thank our speakers again for sharing a lot of really good information and a lot for our audience to consider and use as they craft their own messages and strategies for talking to and reaching community members about these routine adult immunizations. So we really appreciate your time. Thank you, Dr. Murthy. Thank you, Kathleen. And thanks, community members and others working on vaccine equity, for the work that you do and for joining us today.
Thank you, everyone.
Really appreciate it.